Dr. Phillip Lee.
Thank you, Mr. Deputy Speaker. NHS hospitals face mounting financial, workforce and demographic pressures. The stark reality is that healthcare provision in the future will require a real need for consolidation of acute and emergency services in fewer locations and an increase in the provision of chronic care in the community through locally based clinics. This is not a political choice, but rather a clinical-driven reality. It is widely believed among the medical profession that the reconfiguration of hospital services can provide a powerful means of improving quality in an environment where money and skilled healthcare workers are scarce. In some places, reconfiguration and changes to hospital services are already a necessity, not an option. This is the case in the Thames Valley region, of which my constituency of Bracknell is a part, and this is why I have recently introduced a healthcare strategy proposal for the provision of healthcare in the Thames Valley region, in which I call for a consolidated, what some have described as a super hospital on the M4 at Junction 89. The so-called Royal Thames Valley Hospital, if it is ever built at this location, would bring about crucial advantages in terms of the use of existing transport infrastructure, thereby allowing service to the greatest possible size of population within easy reach of their homes. This model has a multitude of benefits, which include economies of scale, sharing of medical information, sharing of manpower, and is supported by many senior medical professionals as being the key to saving the National Health Service. Nevertheless, I sense a lack of strategic leadership in this area because that is what's required to deliver the change that we all need. A major stumbling block in many hospital reconfigurations is public concern about change and political opposition that follows as a consequence. Politicians will have to make decisions based on the quality, safety and efficiency of healthcare while retaining strong public engagement in that decision-making process. That is why I've already begun holding regular public meetings throughout the Thames Valley region.
On that point, would you allow me?
Of course, I'll give way.
I'm grateful to my honourable friend. As he knows, he's set a number of rabbits running in my constituency. Will he just concede that there are a number of professionals, both managers and clinical in the NHS, who differ with him and think that a network of hospitals is an effective and incremental way forward?
I thank my honourable friend for that intervention. Yes, I would concede that there are not many. There are some clinicians locally who share that view. I would suggest that often whenever you present something that is different and that is a challenge to the status quo, you're always going to come up against vested interest, particularly in the National Health Service. Many of my colleagues within this chamber do need to start engaging with the public on this issue. It is coming round the corner and we all should try to provide the political environment in which this change should take place. In my speech today, I would like to first set the context of why I'm supportive of this need and talk about the current difficulties within the healthcare system and those which we will face in the future. The context, well, in the past 50 years, according to the King's Fund, the number of acute hospitals is reduced by 85%, and the number of sites in which elements of highly specialist care is delivered has reduced even further. In England, general acute care is now delivered in just over 200 hospitals, and at the same time, the average size of hospitals has grown from 68 beds, Ministry of Health's document 1962, to just over 400 beds. The average acute trust has just over 580 beds. These changes reflect developments in medical practice. Advances in medicine and surgery have driven clinical staff and equipment to become more specialised. As skilled specialist staff are scarce and budgets are limited, services have been centralised onto fewer, larger sites in order to ensure patients are cared for by staff with the necessary skills and supporting specialist equipment. In addition, there has been decreasing reliance on bed rest as part of treatment. For example, most routine surgery is now undertaken as day surgery. The average length of stay in hospital is currently just less than 6 days, and 80% of all patients have stays of less than 3 days. Having surveyed both NHS trusts and the public on service change, the Foundation Trust Network have found that 90% of NHS trusts said that a major change, such as a hospital merger, closure or changing the way services are provided, was necessary in their area in the next 2 years. Critically, 8 in 10 trusts felt that a reconfiguration in their area would lead to maintained or improved patient outcomes, which would not be possible if the change did not take place. Of those NHS trusts indicating that a reconfiguration would be necessary, 35% felt that there was a consensus locally about how this should take place. Local councillors were felt to be a barrier to service change, 49% were in those cases, as were NHS trusts themselves, 48%, and MPs, 40%. Finally, market research organisation ICM polling of the public shows conflicting views. 4 out of 10 people initially stated they would prefer to be treated locally, but when asked to rank the importance of having services close to home versus accessing specialist care when being treated for a serious condition, over half said that it is more important to be treated in a unit that specialised in their treatment area. That number rises to 60% if the respondent is talking about a loved one receiving the treatment rather than themselves. 3 in 10 said it was most important to have a hospital close to where they lived in this case, suggesting that why people value the convenience and accessibility of local care, ultimately access to specialist expertise matters more when a serious condition is involved. Demographic changes and the shifting burden of disease will require a fundamental shift from the hospital as the core focus of health service delivery to the community, i.e. to provide elective care and minor treatments from the community level in much cherished community hospitals and all major surgery and acute care from a central hub hospital, ideally located on a motorway. In any reconfiguration of hospital services, there are 4 drivers: quality, i.e. better health care, workforce, cost and access. The challenge is to try and arrive at a configuration that optimises all of these elements as far as this is possible, given the complex trade-offs that exist between them. Quality considerations include access to highly trained professionals in all disciplines, compliance with clinical guidelines, access to diagnostic technologies and other support services, as well as strong clinical governance. More recently, there has been pressure on trusts to meet challenging funding needs, which is putting greater emphasis upon operational systems and environments to work together to meet the targets and improve patient safety in acute care settings. There are also interdependencies between services. For example, withdrawal of paediatric services can threaten obstetric services, which rely upon paediatricians to provide care for the newborn child. There is a wide variation in the quality of care delivered by NHS hospitals. Reconfiguring services can be a powerful means of addressing this variation. An often cited successful example is here in London. It has been estimated that the recent configuration of stroke services will save more than 400 lives a year. This is through the establishment of stroke networks that have concentrated specialist stroke expertise and diagnostics in fewer units while retaining local access to stroke rehabilitation services in local community hospitals. Other examples include vascular surgery, where the mortality rate is lower in high-volume hospitals than low-volume hospitals, and paediatric heart surgery, where there are plans to cut the number of hospitals undertaking surgery to improve outcomes. It is also estimated that stroke mortality rates across acute hospital sites across England would be 2,117 fewer deaths per year from stroke in England, with increased ambulance services to specialist centres. This clearly demonstrates that centralisation of stroke and trauma centres would benefit a larger proportion of the population and would reduce mortality rates and thereby improve the quality of care. Alongside these changes, there is a need to shift the location of care for older people who do not require specialist care in a hospital setting. The Royal College of Physicians estimates that almost 2/3 of people admitted to hospital are over 65. People over 85 account for 25% of bed days. As we have noted, older people make up the majority of patients in hospital beds, and yet many could be cared for elsewhere if appropriate facilities were available. End-of-life care, in particular, illustrates the inappropriate use of hospitals. Notwithstanding recent increases in the proportion of people dying at home, many still do die in hospital, although they would prefer to be cared for in a hospice or in their own homes. One of the challenges here is to make community services available 24/7 to stop hospitals becoming the default setting for lack of other options. Moving on to workforce pressures, since the application of the European Working Time Directive to junior doctors, there has been a 50% increase in the number of junior medical staff required to fill a rota and provide 24/7 care, and many units have struggled to achieve this. According to a report by the Royal College of Physicians, 3/4 of hospital consultants report being under more pressure now than they were 3 years ago, and more than 1/4 of medical registrars report an unmanageable workload. And I draw colleagues' attention to this document by the Royal College of Physicians. It's well worth a read and should be borne in mind when discussing and defending local hospital services. Recruiting into emergency medicine is also becoming difficult, and application rates into training schemes involving general medicine is also in decline. According to the RCP, there is an increasing reliance on locums and unfilled consultant posts. This will have a negative effect on emergency care, which is most vital to all. There is also increasing recognition that services such as emergency surgery may be unsafe out of hours, and the provision of these services needs to be concentrated in fewer centres that are better able to provide senior medical care. Improving the quality of care often entails making available senior medical cover in some services on a 24/7 basis. This in turn means reducing the number of hospitals providing these services to enable consultant medical staff to operate effective rotas in the evenings and at weekends. This would also reduce mortality rates, as most deaths happen on poorly staffed wards on weekends. The most contentious issues concern changes in the provision of accident, emergency and maternity services because of the importance attached to these services by patients and the public. Many of the changes derive from workforce shortages, for example among consultants and midwives, making the current model of care unsustainable. This is leading to increased differentiation in how these services are provided. For example, some hospitals providing midwifery-led maternity care and others no longer providing A&E services at night. Moving on to cost, merger of particular services such as intensive care, A&E services and cardiac surgery could improve quality and save money. NHS London, for example, demonstrated that the recent reconfiguration of stroke services has achieved improvement in quality as well as significant cost savings. In the last quarter of 2011-12, the DOH estimates that 10 out of 72 NHS acute and ambulance trusts were rated as underperforming or challenged on their financial performance. Of 143 foundation trusts, Monitor reports that 10 had a financial risk rating of 1 or 2 on a scale of 1 to 5, 1 being high, and that 11 were in breach of the terms of their authorisation on financial grounds. 20 trusts have declared themselves unviable in their current form. I include in that Heatherwood and Wexham Park NHS Trust that serves part of my constituency. One of the most comprehensive reviews for clinical and financial evidence was Lord Darcy's review of the NHS. He argued that future technological advances would result in an expanding number of diagnostic tests and therapies that would be more cost effective to provide in a smaller number of regional specialist centres, such as what I suggest for Junction 89 on the M4. Rather than a larger number of low-volume district general hospitals, which is currently the case in large parts of the country. Future technological advances would result in an expanding number of diagnostic tests and therapies that would be more cost-effective to provide in a smaller number of regional specialist centres rather than a large number of low-volume district general hospitals. The Audit Commission, for example, has identified 25 operations or admissions and estimates that 75% of surgeries should be carried out as day cases. The Commission estimates that if all trusts received an average 75% day case rate across these procedures, then at least 390,000 bed days would be freed up. This would save £78 million based on £200 per elective patient bed day. Lord Darcy further explains that minimally invasive techniques will continue to improve. In the next 10 years, endoluminal surgery, that is, entering the body through its natural holes, such as the throat, will become the standard method of treating many complex cases. Better diagnostics will also help most surgery to become non-invasive. Minimally invasive surgery means smaller scars and less risk of post-operative infection, i.e. patients also recover more rapidly. Furthermore, there is also an argument for reducing the number of administrative staff required, which will lead to being more cost-effective and money will be better spent on the quality of care. Hence, reconfiguration can deliver improvements in quality and safety without significant additional cost. Now, moving finally to access, there are strong political and policy pressures to sustain and, where possible, increase local access to services, particularly those needed in the emergency, such as A&E and maternity. All of this needs to be borne in mind. With an ageing population, the majority of hospital users will rely upon public transport to get to and from hospital. Clearly, if you're going to do this, you're going to have to put in the transportation systems required in order so that the population can access these central hub hospitals. So finally, in conclusion, after all of that, what I would suggest is that in order to get to the stage, this utopia that I'm seeking to try and achieve in the National Health Service with regards to where the hospitals are located and how they should be structured, I fear we need something that we don't have, which is some central direction. I think we do need some form of a committee, dare I say it, a cross-party committee, because this is going to take many, many years, in order that we can draw up a plan that applies to the whole of England and Wales, so that we can decide where those hospitals should be located, and just as importantly, where the community hospitals, which will be needed, should be located within our communities. By doing this, I am convinced that we will be then in a position to deliver the very, very best care that we know in the Western world to all of our constituents when they clinically need it. Thank you very much.
Minister. Thank you, Mr. Deputy Speaker, and I congratulate my honourable friend for both securing the debate and today, and for making what was a very eloquent speech about the importance of modernising the NHS and continuing to deliver high quality care, and that the fact that, as we know, delivering high quality care and improving patient care actually often goes hand in hand with improving efficiencies in the way care is delivered both to patients and sometimes reducing the cost of delivering that care. My honourable friend outlined very well that the system that we have in the NHS, and as the NHS has grown up, we have a crisis management system in the NHS that focuses around the acute sector, and perhaps if we were redesigning the NHS today, it would look very different. And I think my honourable friend has made very clearly the case about the importance of community delivered care and the fact that we need to keep people living well and healthily in their communities rather than picking up the pieces when they get unwell in the hospital setting. He made the point quite rightly that the period that people now have in hospital stays have considerably reduced for surgical operations. I think it's gone down from about 9 or 10 days over the last decade or 15 years to an average of about 5 or 6 days now, and the increasing use of keyhole surgery and other forms, and laparoscopic surgery and other forms of minimal invasive procedures have again increased the quality of care we can provide, reduced the cost, but importantly made sure that patients are treated in a better way, in a more effective way, that also has regard to the fact that people are much better off in home than in hospital, or being treated as day cases rather than as long-term admissions. My honourable friend was absolutely right to also highlight the fact that we now have a big challenge facing the whole of our health service, the fact that we have many people with long-term medical conditions to look after, many older people, and this is the big challenge that faces the NHS in the decades ahead. And the fact that as we have people who are living longer with diabetes, with heart disease, with dementia, that actually the way to look after these people isn't to wait for them to get unwell, to pick up the pieces when they become unwell and they find their way to A&E, but to prevent them getting unwell in the first place and deliver more care in the community and focus on prevention where we can rather than cure. And also it's about, as you quite rightly highlighted, that we need to do more to ensure that we have proper rehabilitation available for people after a stroke or an operation, and that needs to be delivered as much as possible in the community and in people's homes, because that produces much better care. And we know that we already see good examples of where this is working. In Wigan, for example, there's been a cost saving to the NHS of £700,000 through actually a new service that does exactly that, which is about making sure that people who have suffered a stroke and no longer spend 50 days in hospital, but are in hospital for a much shorter period of time and get the vital rehabilitation care and care they need to actually improve the outcome that they have had from that stroke and improve their recovery, but that care is now delivered in the community rather than the hospital setting. That's cheaper for the NHS, and it's also much, much better for patients, which is something that is a good model of care we can take elsewhere. And I think the other point my honourable friend made, Mr. Deputy Speaker, was that actually it is important that politicians are brave in the way we talk about these matters. And I think my honourable friend deserves, should be commended for the way that he's approached the issues and being very honest about the fact that in future medical care is going to need to look different. And sometimes the politician is the worst enemy of the physician, and we are both medical doctors. We both still practice medicine, and we understand that actually what good care looks like is going to be different in the years ahead. And it's important also that we make sure that we put across the case in our role, both as physicians and as politicians, to make the case that actually what matters is delivering that high quality patient care, and what matters is actually the way that actually is the quality of care available to patients, and that will have to look different if we want to deliver more care at home, more preventative care. And he also there touched upon the need sometimes for service reconfigurations that do have specialist centres and more focused centres of care. And he outlined many examples in that, how the reconfiguration of stroke services in London was massively to the benefit of patients, and having fewer centres for stroke care has actually been saving many hundreds of lives every year, and there's good clinical data to support that. Similarly, I was yesterday visiting hospitals in Manchester, and a very good example of where service reconfiguration has worked is where a case was made very clearly for reconfiguration of maternity care and neonatal care in Manchester. That's saving for having fewer obstetric-led maternity units and having more midwifery-led units. That's saving the NHS money, but it's also making sure that we're saving 30 babies' lives every year in the Manchester area. And Mike Farrer, who was the former head of the SHA, delivered that very effectively. I'll come to the service reconfigurations in my honourable friend's part of the country in a moment. But one key thing we can draw out of the example I just gave about Manchester and about London is that although I hear what my honourable friend is saying about nationally led service reconfiguration, these changes to services were led at a local level by good clinical leadership and effective engagement of local communities at a local level. So I think there's very good examples which my honourable friend outlined in his speech, where strong local leadership, strong clinical leadership at a local level has actually delivered improved patient care as well as saving the NHS money. And that money, of course, is actually being ploughed back into the NHS to improve care for other patients. So turning very quickly to the issues of service reconfiguration in Bracknell and in my honourable friend's part of the world. As he's aware, the government and this government, as previous governments, have set a number of tests for service reconfiguration. What these tests, there are four key tests. The first is that whilst it's important that local healthcare services should be designed around local healthcare needs, the government, as I outlined, is clear that there should be a consistent way in how the NHS develops and implements plans for service change, which gives confidence to local communities. And that the four tests that were set out outline very clearly that there should be strong local clinical leadership and ownership of the way that services are redesigned. There should be strong community engagement, and we know that, as from the example of Manchester I gave earlier on, where community engagement is done effectively and communities buy into that change because it saved 30 babies' lives every year, the changes, that actually then effectively we can deliver high quality and better care for patients, but also we bring the community with us in doing that. The third test is that, as well as being clinically led, that actually it should encourage choice and availability. And also in more rural parts of the country, there's often actually part of providing, having bigger and better centres may in fact potentially reduce choice, because with rurality, we sometimes need to have more service providers, more hospitals, because of the very nature of a very rural area and the fact that people have very long distances sometimes to travel to receive their care. And finally, that the key focus should be that even if, yes, there may be cost savings to the NHS in the changes being proposed, that actually the focus should be that it is delivering higher and better quality patient care. So if all of these four tests for local reconfigurations can be met, then that is something that I think we should all welcome. And that's an example that my honourable friend has outlined we've already seen working well in London and Manchester and elsewhere in the country. So I will now sum up, Mr Deputy Speaker, if that is acceptable to you. The challenge, I'm very happy to meet directly with my honourable friend to talk through the service reconfigurations that he is advocating in his part of the country if he wishes to talk about this further. But I think the key message that we need to send from today is, and I know my honourable friend has already been talking and working with the PCT and the Strategic Health Authority in his part of the world, and also working with fellow MPs whose constituencies and constituents and hospitals will be affected by this. And I urge him to continue to engage at a local level with the PCT, with the Strategic Health Authority, continue that engagement and continue to engage with colleagues. And make sure that he continues to advocate the case for what he is suggesting. And I'm sure if he continues to do that, he will make sure that he brings people with him, and he will also put across a very strong case for the change he's advocating. However, it is important to stress once again that these decisions will be taken at a local level. As PCTs turn into commissioning board, local commissioning groups, it will be again for those commissioning groups to come together, to work together, to decide how healthcare services look like at a local level. And I'm sure my honourable friend will want to continue to engage with them, as well as parliamentary colleagues and other healthcare colleagues at a local level, to put forward his proposals. And I'm sure, given the eloquency of how he put it forward today, he may well have some success. Thank you, Mr. Deputy Speaker.